Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast. My name is Terry Fletcher. Today is the 198th episode of the CodeCast. We're in the first week of August. Can you believe we're almost through the summer already? It's amazing to me. And we want to really just talk about some of the breaking news that has been coming out, not just with Medicare, but with some of the executive orders and the Surprise Act and just some things that have been happening with the inpatient list only. And I want to explain what that is and just some things I really think that you need to be updated about or you may have missed in the news because there's such a flood of information. So let me get started with something that came out on July 19th. And this was an unprecedented move by CMS that, for some of you that don't know, what CMS did is they proposed in the 2022 outpatient prospective payment system, the OPPS rule, that they put back on the inpatient list all of the procedures that they removed from the inpatient list starting this calendar year. So they're doing this basically in the midyear. And I just find that this is interesting because the agency, meaning CMS, also put a halt to its 3-year plan to completely eliminate the inpatient-only list. And for those of you that don't know what that is, this is a list that basically says to payers, Medicare, but I know that a lot of the other commercial plans adopt this list, what should be admitted as an inpatient before you can do a surgery, and then what can be done in a surgery center or in an outpatient setting. And you know this is big on cost. Inpatient surgeries are really expensive. And so it appears that this is motivated to protect the safety of Medicare beneficiaries and to take a more cautious approach to removing services from the inpatient-only list and then looking at them on maybe an individual basis rather than by class. And there's still 5 months in the year now. So what do physicians and hospitals do with this information at this point? I was reading an article by Dr. Ronald Hirsch, MD. He's Vice President of Regulations for R1 and RCM Incorporated. Also, a colleague of mine, he is somebody that also helps moderate the RAC monitor on ICD-10 monitor. He's on Mondays, and I'm on the Talk 10 Tuesday on Tuesdays. And so we've had a lot of discussions on healthcare, but his comments on this is, since the audit moratorium basically remains in place for all of the procedures removed this year, and CMS has admitted proceeding too quickly with the removal process, he says it may be reasonable to tell physicians to maybe disregard the complicated decision-making process that we wanted them to undertake and go back to admitting everybody as an inpatient starting today that they felt was necessary from a risk standpoint on that surgery. But then he says, he cautions and he says it's a compliance issue. And you really can't ignore the status recommendations that are still technically and legally in place. So what you're really looking at is that every compliance officer that's really in the country is going to have to assess and decide very quickly how they're going to deal with this inpatient list only that's now been put on hold. Now, the AAOS, the American Academy of Orthopedic Surgeons, also weighed in on this, which I think they would because this really impacts them. But they said they're encouraged by the CMS proposal, but much work is still left to be done because the halting of the elimination of the inpatient list, and it really returns 298 musculoskeletal services to the list. And two of the most notable changes by this week proposed, they're really looking at total knee arthroplasty from the inpatient list. They did that actually in 2018, and that can be possibly considered moving back in. And then total hip arthroplasty. So when you're trying to repair, a hip issue or actually replace it. Those are things that a lot of the orthopedic physicians have said that is not safe to do in, let's say, an ASC. I know Dr. Guy, president of the American Academy of Orthopedic Surgeons, he says that he hopes that their, advocacy for trying to make sure that patient safety is the first thing they're looking at They said we continue to support the removal of procedures which have been proven to be done safely in the outpatient setting. However, there is much work left to be done to clarify what these changes mean in order to avoid widespread confusion and unintended consequences for patient care. What that means is that CMS has to be very careful by creating, new regulatory barriers and determining the appropriate setting of care as an overcorrection to a policy reversal. Because now that the country has benefited from certain flexibilities and certain individualized medicine during the pandemic, allowing certain things because we had to have those makeshift hospitals as ASC and things like that, allowing the physician to make that determination. The physician has to make the decision for that patient individually and their clinical profile if they need to be inpatient or outpatient. I just don't see it being completely done from a legislative perspective. So it'll be interesting to see what this breaking news does, because it is going to be confusing for payers if they think, especially let's just take United Healthcare, one of the biggest payers out there. They say that, Medicare says that a certain procedure should be done as an outpatient. So they're going to say, we're not going to pay for it as an inpatient service, that it doesn't qualify. And so that can be very confusing, especially if somebody says, we follow Medicare rules. Well, if Medicare has a rule in place and then they rescind it, but it's a proposal and it's not really rescinding the legal position yet, it's just going to be basically a nightmare. So hopefully we'll see where this ends and, what we need to instruct our compliance physicians, but you definitely need to be aware of it, or this could be a problem, coming down the pike. So then I want to turn our attention to surprise billing. And I think there's a lot of confusion out there. I might have mentioned it recently on a podcast. I know I did mention it on my Medicare quarterly update webinars. But banning surprise billing, what that is really related to is hospital billing, mostly things that happen in the hospital. So it is Part B and Part A. But it's for patients that need emergency care and they don't have an option or an opportunity to approve or determine if they want the care from a non-contracted or non-participating physician. So they call them out of network. And the No Surprises Act says that they have to be treated as if it was an in-network situation. But on July 1st, just in time to meet statutory deadlines set by Congress, in the Department of HHS, there was a new IFR, interim final rule issued, along with a press release, which adopted some broader parts of the ACA and talks about this surprise bill, and also known as balance billing. But here is what came out of that, and I just thought it was interesting. So it says the balance billing exists in both emergency and non-emergency situations, extremely high surprise out-of-pocket for patients. And they're talking about the implications for negotiations between payers and providers. And some providers use the threat of balance billing to obtain higher in-network reimbursement from payers. This is definitely going to hurt physicians. It's helpful to the patient, there's no question, and it'll help lower medical debt, but it's going to hurt physicians that run to the hospital at 2:00 in the morning to help somebody who's in need, because it'll say that a patients need to be treated as by an out-of-network provider at the same cost price, same cost threshold and cost sharing that it would have been paid if the service had been provided by an in-network provider. And, it really bans providers and facilities from sending balance bills to patient to collect a higher amount than that. But what the confusion is patients are reading this thinking that they don't have any amount, or that this also applies to services in an office setting. And that is not the case. So these projections and this information will go into effect January 1st, 2022. But one of the biggest things that starts on the balance billing provision is it really talks about you can't deny coverage for care received in an emergency setting based solely on diagnostic codes. You have to make sure that the patient is, and these are the facilities, what they have to do. They have to first make sure that they have a price, basically threshold, that is equal to the application of an in-network patient. And it also talks about emergency services. You cannot deny care for patients that are pregnant, and especially if their plan excludes dependent maternity care, an exclusion that advocates you can't discriminate on the basis of sex on a patient. These are things that I definitely am on board with, of course. But the thing that talks about, denying coverage or coverages that can't pay more out of pocket for the patient. If you're a Kaiser patient and you've paid, or your employer covers your health, and you know that you have a certain hire for ER, but if you go to the ER that you want to go to out of convenience instead of go to a Kaiser facility, that you're going to get treated the same. To me, that's almost unfair to patients that are really trying to get care based on where their location is. So I think this is going to be really interesting when it comes to how they're going to enforce it and make sure that it's appropriate. What this really came up from, just so you know where this started from, it was for facility and ambulance services. Ambulance services is who has the history of sending extremely high surprise medical bills to patients. And the protections actually apply to transport by ambulance, air ambulance, and helicopter as well. Those were things that were just completely out of the patient's hand. But now that they are putting it into hospital services as well on the Part B side, some of the most common surprise medical bills are from out-of-network providers that provide ancillary services. So let's say it was an emergency when they came in, but now they want to call in a specialist after the patient's been there a couple of days. So a radiologist or anesthesiologist or pathologist, or maybe a specialist to respond to unexpected complications, maybe a neonatologist or a cardiologist. So they can't, these kinds of specialists also will prohibit surprise bills in the No Surprise Act, which is the acronym NSA. It's limited in circumstances, though. A patient can knowingly and voluntarily agree to use certain types of out-of-network providers. So if they want to select an out-of-network orthopedist for a knee replacement, or an out-of-network obstetrician for a scheduled delivery, then they can, sign a waiver for those protections and agree to the balance bill. What I'm afraid this is going to do is the physician may show up and say, what's the patient's insurance? Find somebody else. I hope that doesn't happen, but when you start to really push the physician's feet to the fire and say you're going to get paid less for doing more work, I could see this being just a really big problem. So nothing requires a provider or facility to seek consent from a patient to waive the No Surprises Act protections. It's entirely up to the providers and facilities to do this. So we do expect that some providers and facilities will use notice and consent waivers. And they do estimate the cost of more than $99 million annually in time spent by patients and families to read and understand these forms. And so just so you know, this is going to be really interesting when this comes up and next year. And I just think that as much as I appreciate the spirit of the rule, I think that they've taken it a little far. So it'll be interesting to see how they actually enforce these rules within the agency. Now, another thing you need to be made aware of, and this has to do with Uber, and I don't know if you're aware of this, so we call it Uber Healthcare. Basically, be careful when you think that during the pandemic your patient still can get a cheap Uber ride to your practice, because right now they're saying that their average wait time is almost 23 minutes, and they usually have 5 out of 10 cancellations for an average of a 1.7 mile ride, which is costing the patient $38. So it's really becoming an issue because during the pandemic, they call it the gig economy. It just was down. They were down drivers. They struggled to, get anybody to want to drive during the pandemic. And then they came out and said, we're going to now help get patients to their doctor appointments. And we're noticing now, as we are now months and months over, 17 months into the pandemic, and the public health emergency was just extended now until through October 20th, that Uber is now saying, well, we did our part last year, but we're not necessarily going to do it anymore. So just be aware if you're referring that out, be very careful about that, because that's something that you may be referring to your patients to, and it could be very expensive. And we just don't want to get in the policy of that. Otherwise, the patients are going to have a big bill there that they were not aware of. Okay, so I wanted to bring an interesting coding question today to you. And actually, it comes from an email I received from Coding Intel, which is a service from Betsy Nicoletti. So I love being a member of her service as well. I also have a membership service, but she puts out little tidbits every once in a while, usually from all the feedback she's getting from her emails. I do that as well. And one of the things that came up is the code G0444. And, basically, does it have to meet the full 15 minutes, or can you use 8 minutes of this code? And what is the correct information versus the misinformation out there when it comes to time visits? And she said the reason for this question is that some codes follow the CPT unit of time rule that's in the front of the CPT book. So some codes require the full length of time, and CMS also gives their MedLearn Matters articles and guides update when it comes to developing a code and what the actual code says. And so when we talk about the G0444, this is for annual depression screening for a patient. And so we want to make sure we know what the definition is. But the interpretation of the time codes is that unless CPT or CMS says otherwise, then you can follow their unit of time rule that basically says that you have to hit half of that time before you can bill for the time that's in the actual time that's descripted. So basically what it says in CPT, it says a unit of time is attained when the midpoint is passed. So an hour is attained when 31 minutes have passed. You've seen that in the old prolonged service codes that still exist for non-office visit codes and things like that. But and then you've seen, like, for conscious sedation, moderate sedation, you have to hit 10 minutes to be able to bill for 15 minutes. But the question came up on this rule, and this rule in the guide basically said you do have to. There wasn't a clarification about this. CMS was silent according to what Betsy put out there, and so you have to hit at least 8 minutes, I would say, to get the full 15. But let's just talk about our new prolonged service code. So the 99417 and G2212 for Medicare both say that you add on to the level 5 visit. Both of those say to use them when the full 15 minutes is met. So you have to make sure that you are understanding the rules and how they develop, and really looking at that information before you can, and the language and the rules before you can report it. There are also some remote monitoring codes. I talk about this all the time with chronic care management and the CCM codes. They talk about this as far as you have to hit a minimum of 20 minutes a month. And it even says, do not bill for this for less than 20 minutes. And so just know the different interpretations, the different payers, and what they're telling you about this, or you could possibly be coding this incorrectly, and we don't want you to do that. Our coding question is brought to you today by CeraVe Daily Moisturizing Lotion for normal to dry skin. Moisturizes and helps restore the protective skin barrier. Developed by dermatologists everywhere. CeraVe. So my personal tidbit today is kind of a fun thing. I celebrated my 22-year anniversary last month, as some of you know. And we didn't really do anything on the date, but my husband came in and gave me a gift card. It was $100 to Roy's restaurant, which is kind of like a Ruth Chris or a Morton Steakhouse type place. Mostly they do fish and things like that. But he said it's only good in Hawaii. So he says, okay, so we didn't get to celebrate our 20th because of the pandemic and everything that happened. And so we are going to go to Hawaii for a week in October. And he usually comes with me when I go to speak at the AAPC convention and conference every September. And we haven't been able to go for the last 2 years because you can't have a large gathering. So that was a big surprise. So I'm excited about that. We stay at the Four Seasons and totally pampered. And I get to go for a week at the end of October. And actually what's really funny, and will tell you my husband, he's like, and we're going during the Pittsburgh Steelers bye, so you don't have to worry about missing your game. Well, yeah, missing it for him too. He's more diehard than I am. But anyway, I'm excited about that. And just a shout out to him for surprising the heck out of me with that the other week. So I'm very excited. So everyone, make it a great day and a great week. And thanks for listening this week. And we'll talk to you next time on the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.